Good afternoon. My name is AJ Scheitler, and I am the Director of Stakeholder Relations here at the UCLA Center for Health Policy Research, and I'm happy to be introducing today's health policy webinar, Reducing Access Disparities in California by Insuring Low-Income, Undocumented Adults. Now, before we begin, I want to let everyone know about next month's March webinar, which will be Economic Insecurity Among Older Adults of Color, Housing and Health as Cause and Effect. Associate Center Director Steve Wallace will discuss economic insecurity among older populations here in California and the Elder Index, and how the housing problem borne by elders, particularly those of color, affect health. The Elder Index is a tool that gives a more accurate measure of poverty based on how much people must spend to maintain a basic standard of living in different regions of California. Again, that's going to be on March 26th at noon, same time. Now, as always, today's seminar is being recorded and will be put on our website for you to view in the future. We also offer a copy of today's slides. You can email Vanitia Lai, whose email address is on the screen, if you would like a copy. And you can also sign up for our newsletter there. Now for today's discussion. The Patient Protection and Affordable Care Act did not extend eligibility for health coverage to undocumented populations, and federal policy prohibits coverage of undocumented individuals under Medicare using federal funds. However, California has extended Medi-Cal, the state's version of Medicaid, to undocumented children using state funds, and efforts are underway to extend that eligibility to undocumented adults as well. Using the latest California Health Interview Survey data on undocumented low-income adults ages 19 to 64, new research led by Associate Center Director Nadereh Pourat reveals the demographics and characteristics of undocumented adults, how their access to care compares to their documented counterparts, and the implications of extending Medi-Cal eligibility to the last remaining uninsured population who have very limited options for coverage. So let's begin the conversation. Dr. Pourat.
Thank you, AJ, and good afternoon. Thank you for joining us today for this webinar. And let's get started. You see my co-author here, Ana Martinez. I wanted to acknowledge that. And also I wanted to acknowledge that this research was funded by the California Healthcare Foundation. And why are we talking about this? So we care about health insurance particularly because healthcare is really expensive. If any of us develops a serious or chronic condition and we don't have insurance and have to pay for it completely out of pocket, many of us will go into debt. Past research shows that a visit to a primary care physician on average costs about $200, which might be okay if it's a one-time deal, but it does not also include the cost of lab tests, medications, or other complementary services. It's not okay for people who are earning $17,000 a year for a single person, or $35,000 for a family of four who are trying to make ends meet and live in places like Los Angeles where the cost of living is really high. An average ED visit could cost on average about $1,300, a hospitalization for a broken leg, $7,500, and a normal delivery anywhere as much as $3,500 or higher. So health insurance is really important. And it is unaffordable for most of the uninsured individuals. The great majority are often low income. The uninsured have limited options for obtaining coverage. You can go to a county-operated hospital or clinic. You can go to community health centers to receive care at sliding scale or free. But even in those kind of places, receiving all of the care that you need is challenging because most of these organizations also have significant demand and supply restrictions. And the uninsured are less likely to receive preventive and primary care services. Of all of the services that an individual uses and needs, these are particularly important because of the potential to address emerging health problems early and avoiding decline in health status and quality of life, as well as avoiding the need for very high cost and intensive care down the road. So who are the remaining uninsured? According to the California Health Interview Survey in 2017, there are about over 2.8 million people still without coverage in the state. But this number is expected to increase to about $4 million 4 million people in 2020, according to other research. Among those in 2020 that are expected to be uninsured, the largest single group is the undocumented population. That's about 37% of that pie. The rest are individuals that are eligible for insurance but do not have coverage for a variety of different reasons. Some of those qualify for employer-based coverage. Some qualify for Covered California subsidized coverage. Some of them, their income is just above the subsidy line, and some of them are eligible for Medi-Cal and are not participating. What are the options for the undocumented to get coverage? The Affordable Care Act extended Medi-Cal eligibility to most adults 0 to 138% of the federal poverty level. It also offers subsidized and unsubsidized private insurance in the exchange marketplace, but it does not allow undocumented to purchase coverage in the exchange, even if it was completely funded by themselves with no subsidies, not allowed to participate. Broadly, federal policy bars undocumented from comprehensive Medicaid, also referred to as full scope. But federal law allows coverage of undocumented using the federal and state funds under Medicaid for restricted scope coverage. This essentially means emergency care and pregnancy-related care. So if those individuals need services, whatever is related to those particular services, it could be medication, whatever, is part of that coverage. But that means that for the majority, great majority of undocumented, for all of the undocumented, if they don't have an emergency condition, they won't have access to important primary care services, acute care services such as hospitalizations, ED visits, etc. Prescriptions particularly. So an individual with cancer, if it's not an urgent condition, they do not have coverage. People who have asthma, diabetes, or high blood pressure cannot get the services that help them manage their conditions. So, in addition to the restricted scope, California actually uses state funds to cover undocumented children. This decision was made and got implemented in 2016. So now all of the children receive full scope Medi-Cal coverage, assuming that they are actually applying and participating. California is now considering coverage of undocumented adults. There are different proposals on the table. For example, one to cover those 19 to 25, but the bigger debate is about covering undocumented adults. What we are trying to do here today is to show, to answer this particular goal, or to provide data to show a comprehensive assessment of the characteristics of the low-income population of California. And what I mean by that, I'll explain in a minute. We used the California Health Interview Survey 2016 and 2017 pooled data. And we restricted that sample to just the low-income populations to be more informative of the debate that's going on. This is the population that's being considered. And those are individuals up to and including 138% of the poverty level. We also excluded children from the analysis, particularly because they're already covered. We also did not include those older than 65 years of age because the sample is quite small, so the estimates were not always, we couldn't provide breakdown of the characteristics, but also because the population 65 and older undocumented is very different with the documented population in terms of their service use and health status. Sorry, very different from the rest of the population. The methodology that we used includes the different indicators that we decided to look at. It included documentation status. We actually used a model to estimate who's undocumented. And you could look at the policy brief for a little bit more detail and another publication that describes how that variable is constructed. We compared the documented, that includes individuals that are native-born, naturalized citizens, and have documentation status with the undocumented. We looked at multiple sociodemographic indicators: age, sex, education, family type, employment, English proficiency. We looked at health status, including risk factors such as obesity or smoking. Looked at chronic conditions, including asthma, diabetes, heart disease, high blood pressure. We constructed a measure of multiple chronic conditions using those indicators. We used the Kessler-6 variable that assesses high psychological distress, and it's a very good indicator of mental health status. And we looked at the following access indicators: usual source of care, doctor visits, mental health visits, emergency department visits. And as I said, we essentially compared the documented and undocumented using these indicators. Now, this is the only place that we were actually going to show a little bit more information across the entire age spectrum, just to sort of show how the two populations differ and what are the populations we are not including in the analysis. As you can see, the documented population is very different in its age breakdown. A big proportion of that is 36% are children. And you can see that the rest is distributed among the rest of the categories of age. But when you look at the undocumented side, you see a very big difference, with the majority of that population being ages 26 to 44. The proportion that are children is smaller, the proportion that are 19 to 25 is not that different, and the proportion that are 45 to 64 is not that different. Big difference in the proportion elderly as well. Here are some of the other demographics that we looked at. As you can see, there are somewhat very big differences, sometimes very big differences, including having 12 or more years of education. A smaller proportion of undocumented report that. Being very proficient in English, a smaller proportion of the undocumented report that. Sorry, a larger proportion of undocumented report that. But also a larger proportion of undocumented report living in families with children. This includes whether you are a single or married adult. And also a larger proportion of undocumented report working, being employed. We looked at sex. We did not find a significant difference, about 52% of documented versus 56% of undocumented. And other data that we have provided before in previous publications also indicate that 86% of the overall population of undocumented are of Latino, belong in the Latino category, as opposed to 25% of the documented population. Looking at insurance status, we also see significant discrepancies in insurance coverage. Looking at the documented population, only about 11% are uninsured. The great majority actually have public insurance, that's 69%. Remember, we're looking at only at low-income populations. And of those that are reporting having public insurance, about 66% are reporting having Medi-Cal. Looking at the undocumented, we are showing that 89% are uninsured. Those 89% include individuals that are reporting emergency Medi-Cal. The reason we're not showing them as insured is because that emergency Medi-Cal or pregnancy-related Medi-Cal is primarily episodic and not comprehensive coverage. It does not cover everything that an individual could possibly need. But 52% of that bar, that 89, are reporting restricted scope Medi-Cal. Moving on to health status. Again, we are seeing sizable differences in health status. The proportion undocumented that report being current smoker is lower. Asthma rates are lower. High blood pressure is lower. Number of having multiple chronic conditions is lower. And having high psychological distress is lower. So what you might ask is whether these differences are accurate and whether these differences are because of some other underlying factors. We did not look at the, we actually measured these, controlled for age and measured it again, and we found the same patterns, so these differences are not because of age differences. But we did not control for a whole lot of other factors that might be reasons for differences in health status. Including access. As you know, if you don't go to the doctor, you won't know whether you have chronic conditions or not. And we looked at indicators of access. The first two bars on the left are showing negative outcomes. Not having a usual source of care and not having seen the doctor at least once last year. Why we're looking at these indicators? If you don't have a usual source of care, the chances that you actually are going to go, being able to actually get in the door is a lot smaller, right? So, and also providers, as you know, often send you reminders and bring patients in for their preventive care. Not having the usual source of care, you also don't get those kinds of preventive services. Not having been to the doctor at least once means that you probably didn't get your preventive services that you should have, whether it's screening for cancer, whether it's flu shot, whether it's any of the other preventive care that's needed. We also looked at higher levels of utilization by looking at the proportion of individuals that had 5 or more visits. And you can see the same kind of discrepancy. The undocumented are much less likely to have had a lot of office visits. Having any mental health visit, again, an under representation by the undocumented population, and also a lower likelihood of having had an emergency department visit. You're looking at across-the-board differences in use of services. So it's not that they're not going to the doctor, but they're going to the emergency room. You're not seeing those kinds of differences. Actually, before I leave this and this one, I'll go back to the health status. There were a few other things that we looked at that were not different. That's why they're not reported. We did not find differences in the rates of being in fair or poor health. That's self-reported health status. We did not find significant differences in diabetes, being overweight or obese was not significantly different either. You can find all of these numbers in the text of the policy brief. In terms of access, we also looked at self-reported delays in getting medical care due to cost. We didn't find a significant difference there. And delays in getting prescription medications was not significant either. So what did we find? What are the findings showing us? Undocumented low-income California residents under 65 years of age, mostly working-age adults, and have children, so they are family members. They're mostly employed, but mostly uninsured. They seem to be relatively healthy based on this analysis, but they also lack a usual source of care or often go without any doctor visits. So what we're seeing is that we are leaving a large number of uninsured without viable options for coverage and adequate access to care. And these are important because they have negative public health consequences. Timely access to affordable care is needed to maintain health. As a community, we all benefit from a healthy population in many different ways. It is up to us to find ways to reduce access disparities for our collective benefit. So what we'd like to do is increase opportunities for obtaining comprehensive and affordable health insurance. Other research indicates that obtaining comprehensive and affordable insurance is likely to reduce access disparities. And also other research shows that Medicaid expansion has been associated with reduced mortality and improved health status, as well as better access to care. And as you know, the policy brief is already available online. You can look at that. And also, you can contact us with any questions. And I think we're ready to go to the question and answers.
Any questions for Nadereh? Any questions? Ying Ying.
Since I'm coming late, so I may ask question you mentioned. So have you tried to look at people who had a doctor visit and then look at prevalence of chronic conditions and other indicators?
Right. We have not. So this is actually a first stage of some of the analysis that we are conducting. Our goal here was primarily to provide a basic overview of the undocumented population characteristics, including their access, but we did not set out here to identify the reasons for differences in access and reasons for differences in health status. That's something that we're going to be looking at later.
Thank you.
It looks like there are a few online questions coming in, but they're not coming across yet. So, anyone else in the room? Okay. Anyone else?
I wanted to know if the usual source of care, did you see if it had a high incidence of clinics, community clinics?
Where are they reporting their usual source of care? We did look at that. I don't remember the numbers, but there are reporting more clinics and hospitals. It's a little bit more complicated to interpret exactly where they are going. Obviously, if you don't have insurance, you'll be looking for kinds of places that are either willing to see you free of cost or are willing to see you at a discounted rate. And we know that kinds of places that do that typically are community health centers and county hospitals, some other hospitals. There are other private providers that might provide reduced cost care as well.
We have a question from online. Has anyone calculated the cost of covering undocumented adults with Medicaid compared to the cost of emergency care of undocumented adults?
I believe others have. I think there are studies that are conducted by other folks here at the center as well as UC Berkeley, and you should be able to find those online.
Do I have another question from the room? Great.
Great presentation. I believe you said that delay in access to care and delays in access to prescription were the same, right, between the two groups. Is that right? And I'm just wondering if you have any thoughts about why that might be.
Right. Well, speculation is always a good part of research, right? It's the fun part of research. I mean, I can certainly speculate. So what we saw that people are not reporting, they're reporting the same rate of delay. Why? If you don't even try to seek care, you know, it's not even, it's just sort of not part of the consideration because you know you're not, you can't afford it. Maybe you don't even delay it. You know, you don't talk about it. I don't know. I really don't know why. In the past, we have done other research, and I think delay differences were significant. I think looking at this without accounting for, looking at delay without accounting for some of the other factors that might explain, such as underlying health conditions, might be part of the reason why we don't see differences there. It remains to be seen. I think we're going to do additional analysis with the data.
Great. Next, we have a question from online. If the data shows that the undocumented don't have health issues, do you think they would enroll in healthcare coverage if given the opportunity to do so?
Right. So that's a really good question. Would you enroll in insurance if you knew that you're healthy? We have, first of all, we don't, you know, if you don't go to the doctor, you don't know whether you have chronic conditions. So we did find a similar rate of reporting fear of poor health, which sort of indicates there might be things going on, but they don't have those particular diagnoses that we're looking for. So that might be one reason why people would actually try to get insurance. And we do have the same problem among documented populations that are not enrolling in coverage. And I think if you're really low income, it really also depends on your ability to pay for it. So if you're right now, the number of undocumented that we're looking at that have private purchase, I mean, we don't show the private purchase, but there are not a lot that can actually afford to buy insurance privately, right? And so if it's free of cost coverage, no premiums, the likelihood that people will participate is higher, especially if you don't have income. And there are other issues there that is beyond the research that we were talking about here. I think there's other political issues I don't think we need to get into that explain why people may not participate in state supported coverage.
Great, thank you. Do we have any more questions in the room?
Yusuke Tsugawa at the medical school. Thank you for the fascinating presentation. I was amazed by the number of the proportion of the undocumented people who are uninsured. Do you have the numbers in terms of among those people, what are the proportion of people who have at least partial coverage through medical or any other kind of insurance?
Right, so the 89% number that is shown here includes about 69, I believe, that had restricted scope coverage, but we didn't look to see if they have got anything else, but they don't. I mean, the reality is that it is very expensive to purchase insurance on your own. They cannot purchase coverage under the exchange, you know, and so the lower cost, you know, it still costs a lot. If you don't have any money, it costs a lot, even if it's a low-cost coverage, right? It's all in the context of how much income do you have.
The next question from online. What are the comparative volumes of the documented versus undocumented population, obviously specifically 0 to 138% FPL, 19 to 64-year-old?
Right, so we actually don't try to estimate the number of undocumented, and that's because there are a lot of different ways of assessing on the size of the population. There are a lot of different numbers out there, and it's not very clear which number is really accurate. I mean, we know that surveys might have, especially when you call people, call land-based numbers, you may not get answers, or that people may not have land-based numbers, or are willing to actually respond to the questions. We know that census undercounts, so we are not trying to estimate numbers from this data. There are other estimates that indicate there are about 2.2 million undocumented in California, and you can use our estimates and multiply it by those numbers and come up with a relative size.
Thank you. Any more questions in the room? I'll take the next question from online. And this is a multi-part question. How do these most recent data compare with prior research on what percentage of undocumented adults in California were uninsured? Has the rate changed over time? And if so, do you have any explanations as to why?
That is an excellent question, whether the rate has changed over time. Unfortunately, I don't remember previous estimates that we have done in the past, but the proportion that are uninsured, I think it's always has been high, and I'm not 100% sure whether that proportion has declined at all. But that is something that actually we're planning on looking at. We are going to look at the rates of insurance coverage among the undocumented in the longer term, so stay tuned for that.
Thank you. What were the 2 or more chronic conditions most prevalent?
Okay, so we did have, these are the specific chronic conditions that we had access to in the data. As you can see, high blood pressure rates are quite high. That tends to be accurate for all populations. I believe so. So heart disease rates are typically lower. Asthma is lower among the undocumented, but it's about 17% among the documented population. And I can give you the diabetes rate that we found. The proportion that reported they had diabetes was 13% among the documented and 10% among the undocumented. We did look at obesity rates. That was 69% among the documented, I believe, and 71% among the undocumented. Obesity, overweight. And then we also looked at fair or poor health, which is sort of a general indicator of health status. And that was about 34 versus 38%.
Thank you. The next question asks you to look a little bit into a crystal ball. If California does extend Medi-Cal to the undocumented, do you think it will be used considering the public charge rule is still pending?
That's an excellent question. We need our public charge experts here, who unfortunately I don't see. It's always a concern. If I was an undocumented person and I had to use state-based coverage, and I knew about the public charge, I'm assuming it will occur to me that this is a tricky proposition. But I mean, we could look at the past. We also have the population that are participating in Medi-Cal, children or the DACA recipients. By the way, our estimates of insurance did not try to identify those that have DACA, which is the deferred action for childhood arrivals. But people have participated, even though by participating, you're actually identifying the fact that you don't have documentation status. So I would expect that people participate. I cannot predict the rate.
Thank you. Any more questions come up in the room? Okay, we still have more from online. The next question is, health access is often equated to health care. Can you please clarify if this applies to the data presented here?
Absolutely. So that's what I was talking about. When we were looking at health status here, we did not account for the level of service utilization. So if you do go see a provider for just the annual checkup, the purpose of an annual checkup is to look to make sure that you don't have any diseases, right? You don't go to the doctor, you won't know whether you have specific conditions, especially if you're symptom-free. Hypertension is a perfect example. You don't go to the doctor, often you won't know. A lot of people don't have any symptoms while their blood pressure is high. A lot of people don't have symptoms if their blood sugar level goes up. To some degree, I'm sure there are exceptions. But so that's the main reason. What we're talking about here is that if you don't have health insurance, you can't go to the doctor, whether or not you have conditions. You're less likely to go to the doctor.
Thank you. The next question starts with a thank you for your presentation, and then asks, for people here in the U.S. on valid visas, what is their immigrant status in this study?
So individuals that have a visa in our data, well, we don't directly identify them because we didn't have that information, but we we looked at the numbers and they're very, very small. So they're not really contributing to any of the results here.
Next question in the room.
I'm Srikant Kayal. I'm a researcher at the center. This is just building off your other comment. Even the fair health, poor health comparisons are dependent on diagnosis of disease. So even the fact that they're the same doesn't mean that underlying health isn't different. So you can imagine that people, the docs who went to the doctor and are diagnosed with hypertension, report themselves as in poor health or fair health, but the undocs don't know, and they might be reporting themselves higher versus the other group. So even those differences, I think we have to think about carefully, because I think when you think about the self-reported health status variable, you think, oh, it's giving me some unbiased representation of baseline health, but it's really dependent on access to care.
That's a really great point. Self-reported health status is subject to a lot of different factors. In fact, we talk about that in the brief. You know, there are cultural differences in how people think about their health. There are a lot of differences associated with being told that you have a condition or not. And so, you know, we're fully aware that our assessment of health status here is not really accounting for whether those are truly people that have a lot better health or not. But you have to also consider, we did it age adjusted. Age is very closely associated with health status, right? So we wanted to make sure that we are not mixing the health of very young people with the health of people that are much older. And we found that a lot of these differences were consistent. So I think once we actually get around to doing those additional analysis, we might find that, you know, people who have better access are reporting different health status. That's possible.
Thank you. Next question from online. Did you research how many of the uninsured, undocumented are currently enrolled in county programs such as My Health LA?
Actually, I don't. So when you look at the public covered among the undocumented, the number is quite small. And those public are essentially individuals that are reporting those types of programs. We don't know exactly what. We don't know if it's My Health LA. We don't know if it's other forms. But there are these other kinds of public programs that are available for individuals.
And do you have any research to show how many seek care in other countries?
Oh, I think in 2001, if I'm not mistaken, California Health Interview Survey had question about the proportion of individuals that go to other countries. But if you think about it, you could possibly go for something specific or confined to another country. Unless you live across the border, it is not a viable option for continuous comprehensive coverage, right? You can't fly every 3 weeks from Northern California to Mexico to get health care, even if you had access, despite the fact that it's cheaper, etc. It's just not a viable thing. So there are people that report, there's past data from, and other research has shown that some people actually go, but they might go for specific surgery. They might go for oral health care specific problem. They might go to get prescription. I mean, there's also people that are might receive some prescriptions, even though it's complicated because that's it's not necessarily legal to sort of import that. So you might, but I don't think that really addresses the main problem that we're talking about here.
Thank you. Any last questions in the room? We have one more from online. How many people were talked to for this study? How many were from Mexico and Central America? Is there data on this?
Okay. We do not identify the nationality of the individuals in the analysis that we've conducted. The California Health Interview Survey, which is source of the data, asks people about their country of origin. And what was repeat the first part of the question?
How many people were talked to for this study?
Oh, okay. The overall sample size, Royce, what are we looking at this year? 21,000 for 2017?
Yes.
But then the total 2016 and 17 is 41 or 42,000 people in California have been surveyed. It's a lot.
Any final questions? Seeing none, I want to thank everyone for their participation and Dr. Pourat for her work in this area, and remind everyone of March 26, 12 noon, we will have our next webinar. Thank you very much.